Okay, interesting. And the extremities temperature was used in the past to determine the degree of shock action. There was an older study about measuring the toe temperature. These British are interesting people. The toe temperature and the temperature correlates with actually the degree of shock. Um, Usually, all the patients who you are concerned about shock or pre-shock, there's basic monitoring that you will do, which include these four, regardless of where the lactate comes from, but on serum lactate elevation is an indication of that. In sepsis guidelines, anything above 4 is considered shock. Below 4, like 3.5, 3.8, is not really as part of the definition, but that's something not to ignore. But in reality, this is something you can monitor. In Europe, they have a modeling score of on examination that will gauge your ability to figure out how severely ill people are. When you have somebody in shock without any mottling, they tend to have a better prognosis. When they are severely mottled to the point that you will see the mottling involving the thigh all the way down to the foot, the survival tends to be extremely limited. Regardless of what the etiology of it, there are several mechanisms by which shock occurs, and in part it's almost always related to a reduction in the delivery of oxygen to the tissues. It's either related to the fact that tissues you are delivering it but you cannot extract it, or because you are poorly delivering it because of the lack of oxygen content, like when you are dealing with respiratory illnesses with poor oxygen saturation, bleeding disorders, or poor hemoglobin. But the majority of times it's related to the fact that there is some problem with the heart. And the problem in the heart can be related to a heart rate or can be related to a stroke volume. If the heart rate is adequate, then the stroke volume can be determined by a preload, afterload, and contractility. These three have to be optimized for somebody to have an adequate stroke volume. With that said, historically we thought that the preload was related to central venous pressure abnormalities or pulmonary capillary wedge pressure abnormalities, and as I'll show you later, it's not really true. Afterload, it's kind of, it depends on how well or how bad people's dilated vessels are, depending on the kind of shock that they're in, and almost always, even in distributive shock, there is, towards the end of it, there's a reduction in contractility, either because of the direct effect of acid on the myocardium or because of the general cytokines that are released that will injure the myocardial muscle. Or you may have a genuine cardiac shock that is starting with a poor ejection fraction from either an acute MI or Takasubu or whatever. So in your assessment of shock, you should think about it in a step fashion, where your first step is to make your clinical assessment to kind of gauge somebody in one category or the other. Afterwards, decide on the volume status of somebody, because the easiest thing is if you have somebody who's actively bleeding or actively vomiting, with diarrhea, it's a no-brainer that the volume is low, and then you start there. When you are in doubt, you have to try to figure out if somebody's, what's the person's preload capacities and whether the fluid replacement will help them or not. And that's the concept of fluid responsiveness. And when you get into that and you optimize their volume status, then and only then you try to go for a cardiac output optimization by other means, depending on the kind of shock that you have, which would make you want to measure a cardiac output as a measurement in order to optimize it. And the last two steps would be related to how good or bad your cardiac contractility is to see if you optimize it. And by knowing all of these steps, I mean, they are put in step fashion, but in reality they are not necessarily in series and not necessarily in parallel. So it's a combination between series and parallel depending on the clinical status that they are in. And when you are in this area of determination, you're actually not only assessing, but also applying some treatment modality, which would be replacement therapy or replacement fluid resuscitation therapy. And by doing so, you will end up with an ability to differentiate shock and initiate adequate treatment. When you think preload, there are two ways to figure out whether the preload is adequate or not, and that's by static parameters or dynamic parameters. Static parameters, when you sit there and you kind of try to make a statement about the central venous pressure or the pulmonary capillary watch pressure, both of which are not necessarily adequate tools because they've proven over time that they are not true preload, unless they are ridiculously low, like meaning that you're dealing with every time you breathe, your CVP goes below zero, it's one thing. But the majority of times when they are in the range of 5 to 8, you have no clue if somebody is still needing fluids or not. With the volume, you can also think about it instead of just thinking about it in a pressure format, in a volume format. Like, do I have enough end diastolic volume if I were to measure a transpulmonary volume status by a thermal dilution technique using one of the newer modalities? Or direct measurement of left ventricular end diastolic volume by echocardiography. And those are static. Like, it's a one-time thing, you don't know what happens if you do it. And then the more logical thing nowadays that we are doing is trying to dynamically figure it out, meaning like you have an action, and according to the action, determine if the volume status improved, indicating that your Frank Starling's curve is optimized. And there are certain parameters that you can look at. One is the pulse pressure variation, which is determined by several, actually these are just kind of some tools that have been, but there are several machines that can determine that for you. Systolic pressure variation, and it can be measured by anything, but as well as the primitive dynamap that we do it. There's the capacity of measuring stroke volume variation, which I will talk about this, and then IVC or SVC collapsibility index. When you are looking at an echo by itself, there are certain measurements that you can make at the left parasternal short axis view and at the mid capillary level by calculating that circle that you have, like the area of the circle can correlate with how good your preload is. The biggest problem is majority of our patients are on the ventilator, and your ability to get adequate windows becomes a little bit limited. If you have good windows, then you can use it as a tool. But again, as a tool by itself is not adequate. The preference is to go towards dynamic assessment. This is one of the oldest studies. I think this is in the way, but this is I think 2000 and I want to say 7. It's nice to have this in the references. Get it? It's a physiology study that they made, and trying to correlate the right ventricular end diastolic volume and the stroke volume with the pulmonary watch pressure, the change in pulmonary watch pressure, and the change in CVP. And you can tell the R is so off, and they're all over the place. So you cannot really look at any of these and determine your watch pressure. However, in the same study, it still looked at if your left ventricular diastolic volume and the stroke volume correlates, and in reality, if you remember your Frank Starling's curve, it really makes it up. So if you are sitting on this part of the curve, any further change in the volume will not make any change in stroke volume. And if you are on this part of the curve, any change, any change in this part of the curve will be any change in this volume will be associated with change in the stroke volume. So which means to you that you want to always be trying to figure out where am I on this curve? Where am I moving on this curve? If I am here, volume volume expansion will be helpful. If I'm here, volume expansion is not helpful in shock states. Another study that really looked at volume responsiveness as it's correlating with CVP or pulmonary arterial wedge pressure, they defined it by a measurement of the cardiac output by Swan-Ganz catheter, and they gave patients 500 cc boluses, and it's either 500 cc. It was at the time when hetastarch was still a volume that was given, and was given as a big shot, two balls, like over a 20-minute period, 500 cc's will be given, and they define people who respond as the ones who have a cardiac index improvement by 15%, and the ones who didn't as non-responders. And how this is how they divided their cohort. So when they looked at CVP, because they had a SWAN, they measured the CVP for everybody, there was not much difference between the two groups, between the responders and non-responders. And when they looked at the wedge pressure, there was not much difference between the responders and non-responders. So just measuring CVP or wedge, if you really have a SWAN, doesn't really tell you that you need to give people fluid or you don't have to give fluids. So this is another proof, and it's not the only one. There are several others, but this one was kind of perhaps one of the better ones and one of the earlier ones. This is a tribute to Dr. Pinsky, who is he hasn't retired yet, but he's still in Pittsburgh. This I shared from one of the talks that I attended. And he looked at several studies that were made in different kinds of patients, surgical patients, trauma patients, medical patients, and they who did the same thing, responders versus non-responders, and he looked at the total and added them all up together. And he found out that it's about 50% of the people are non-responders. That's obviously the opposite. 50% of the people are responders. So when you have somebody in shock, it's a flip of a coin, unless you make some determination. With that said, you have to kind of remember that whenever you're looking at somebody's blood pressure, you have to determine how it comes from. And if you remember, the initial phase is where the blood flow goes to the aorta, and then you have the diastole, where indicated by the aortic valve closure, which is diastole, will start to occur. You have a systole, dichrotic notch diastole. And if you were to kind of make some analysis of this waveform, you'll have an idea of what your stroke volume is, and that's one of the major areas of research for the past 20 years, to look into pulse contour analysis to determine stroke volumes and cardiac outputs. In ventilated patients, it's a very easy thing. You have a ventilator, and if you were to have an arterial line and you're able to determine this, every time there's a breath in, you will be able to tell this, during inspiration it decreases, during expiration it gets bigger. And if you have this variation between the two, you don't even need to make a calculation that this person is going to be volume responsive. Because the ventilator, just by changing the intrathoracic pressure, you're actually decreasing somebody's pulse pressure. So, but for this to be valid, the ventilator has to be at a reasonable target volume, which is about 8 cc's per kilogram. So in those patients who don't have severe ARDS, who can afford a higher target volume that you can keep it in there, this would be a valid tool. In patients who are very poor on compliance and you cannot put them on 8 cc's per kilogram, this becomes impossible to do. And it would be completely wrong to say, well, I'm going to put somebody on a target volume of 8 cc for a period of time and take over. You don't want to risk any further injury to the lung, for one. And two, there is something about the target volume history that the ventilator has, the patient has, that it does not necessarily reflect as well with these things. So in a non-ventilated patient, this parameter will not be a very good variable point to tell. By the same token, as I told you earlier, if you were to take the area under this curve, which is where the flow is, you would be able to tell what the stroke volume is, and if somebody's on a ventilator, if it changes inspiration and expiration, you will be able to determine the stroke volume variability, which is the maximum minus the minimum divided by the average. And when you have that, that parameter will be a valid tool to look into it. The several other studies came after and it became like, oh, this is a great tool to measure, and it was used by several companies to determine that. This is just an illustration for you. Like if you were to look at the pulse pressure variability and how it correlates with the stroke volume, you know, this is determined by this equation basically. Compliance times pulse pressure will be equal to the stroke volume. This is the relationship between the two. This is why if you only have the pulse pressure without calculating the area, that's okay. So it's a much lesser occupation, much lesser calculation, and that's what I mean. So if you're measuring each one of them, and you have somebody on a ventilator or 8 cc's per kilo, and every single beat is the same, then you can say that this patient is on this part of the curve. When it is like this, hopping up and down, you know that they are on this part of the curve. And to go from point A to point B, you simply give fluid. So like you see this paper published this. It was a nice graph. I got it, but in the end they looked at these kinds of patients, gave them fluids, and then made them into this part that they were like dividing them based on this pattern basically. So on this key, imagine your Frankenstein's curve. Here you don't give fluids, here you give fluids. You can do the same thing either with pulse pressure variation, and actually this was a correlation with the if I remember well, it's a correlation between it and the SWAN data, and they looked at the cardiac index as it increased the pulse pressure, just to correlate for you that, you know, the correlation is perfect. And they defined the responsiveness by about 13%. So to say that I have fluid responsiveness when you're looking at the pulse pressure variation, it's 13% in this paper. And when we look at the ROC curve, it looks like the best tool is the pulse pressure variation. Stroke pressure is not stroke. Systolic pressure variation comes second, and there's absolutely no correlation between right atrial pressure and the pulmonary arterial pressure. So you have to keep these two in mind in ventilated patients. If you look at the stroke volume variation, it's 10%. So pulse pressure variation of about 30%, stroke volume variation is 10%. But again, I don't want to make you remember anything really, because every paper defines things differently. So for us, you know, anything of 10% on stroke volume variation, that will be considered positive. We definitely have some limitations for both of them. Obviously, as I said, if they are not on a ventilator, it becomes very difficult to understand. If they have poor pulmonary, everything is off, because the actual pressures and limitations of the right ventricular function becomes a problem. People who are in any form of arrhythmia will give you a hard time understanding these parameters, because actually if somebody is in AFib, everything is all over the place, so you cannot really tell if they are responsible or not responsible. This is 10 to 15%, as I said. So in reality, when you're looking at the preload change, or an effect of preload change that you can have to test for it, you can test for it in 4 different categories. You can test for it by just simply giving volume and looking what happens to either your systolic blood pressure, or if you were having a tool that measures cardiac output, you look at that. You can look at it on a ventilated patient by heart-lung interactions, by making a change on the tidal volume and see if you can achieve that. This is very difficult to do on spontaneously bleeding people, so this is majority of us don't even use that. There's another way that you can do this on a ventilated patient by doing an expiratory and expiratory pause, but you have to do it for 15 seconds. So actually, the machine gives a breath, and there's an exhalation that's empty. At the end of exhalation, before you start the second, you put a block. It's a 15 second. It's very, very uncomfortable for patients usually. But if you have that and you if you close it and you see that the volume rises, like the pressure improves, then you know that there's an improvement in cardiac output by about 5% higher. Now, the one tool that is extremely easy, I shouldn't say extremely easy, it's relatively easy, is the passive leg raising, which is like all of us have about 10 to 15% of our cardiac outputs in our legs. So if you were to passively raise it in a standardized way, like maybe at a 45-degree angle rise, and you immediately check blood pressure, you would be able to tell if things improved or not improved. The problem, hard to tell in people who have neurologic abnormalities, like people who have acute spinal cord injury, this is not valid in them. People who are obese, you don't know the effect of it because you don't really know if you lift it correctly or not. And there is a kind of, because how obese they are, if there is a tightness in there, it's very hard to tell. And if you have somebody with intra-abdominal hypertension, if you say intra-abdominal hypertension, also pregnancy becomes an issue. Everything related to pregnancy will not be valid in here. But it's a very valid tool, and I'm hopeful that we will be able to use it more frequently.
Do you mind if I ask you a question? We're trying to do it a lot, but the thing is, sometimes we don't have arterial line, so we're using the cuff.
Yeah.
But what would you do the difference? Just like the difference in the map, or what would you?
Systolic blood pressure, because I saw it, I showed you.
Yes.
The systolic arterial pressure variability correlates well with that.
And should we use like the 10% that we talked about, like
for I think it's between 10 and 13. It's not 18. I think so. I look it up for you, but it's kind of anything above 10% you can try. It's a reasonable number. If you undershoot, this is a problem. Now, like with a straight leg raising, you cannot overshoot because it's somebody's own blood ring. But once you're done with it, then you have to give about 500 cc's, which is to estimate what's in there, and you give it as a bolus, and then you have to repeat it until you're done with that. So actually, let's see. The stroke volume is 12% in this. So in one of the reviewers in one of the review articles is reference. I should give you the references. Looking at stroke volume and pulse pressure, they realized 12% is a good number. Anywhere above 10, just consider it positive. I'll talk about inferior vena cava diameter variation later on. We don't do this because it's not easy to get the superior vena cava often, but a change like this, if you were to use transvaginal echo, it's probably more accurate than inferior vena cava. 10% for passive leg raising, and the way they tested it as a requirement to measure cardiac output. But that's just in a review article. He was putting a summary of a review. When you're like, if you look at it, as you lift the legs, if there's no change in heart rate whatsoever, but the systolic blood pressure increased, the only thing it's increased by is stroke volume, basically. So that is good enough in my mind. It doesn't have to be a complete measurement of a cardiac output. And expiratory occlusion pressures is you don't need a lot of change to say it positive. Mini fluid balance, like with 100 cc's, I think it's a useless test, by the way. So 100 cc's is like within the error of the 100 cc. This is, how much is this?
300.
It's 12 ounce. So it's I should write 250, 300. It's like actually 333 if you want to say. So if this is like a third of this, Like it will go in the tubing. If somebody splits it, it will be more than a tube. Anyway, and the conventional fluids challenge is about 500 cc's. Key to do a good straight leg raising, you have to take the patient not from flat position to leg, you have to put them in upright and then flip it with the same, right? You'll be like this, and then you get the head down, legs up, so that you have the beneficial effects on it. To determine cardiac output, there are 3 ways of doing it. There's the real invasive way, there's the mini-invasive way, and the non-invasive way. No, as of today, the pulmonary artery catheter is the quote-unquote gold standard. But when you know how it's done, I'll show you soon, you'll have a lot of errors in it, and you have to have a lot of rigid assumptions in order to make. So the gold standard is not really gold; it's close to sand. Mini-invasive is either you use either the FIT principle through carbon dioxide rebreathing technology through mechanical ventilation. It's a very reasonable thing to think about. Theoretically, it's a great thing, but half your patients have COPD, and the rebreathing of CO2 will be impossible to determine. There's the pulse contour analysis that you have, and the one that is increasing utility is the transesophageal Doppler. Like, and I tell you guys, in the next 5 years, transesophageal echocardiography is going to be part of physical examination and ICUs. And then you have the non-invasive. Clinical examination still has some value, but there's more talk and technology relating electricity and how it behaves as you as you put the electric current in the chest and figure out what the cardiac output is. Echocardiography with Doppler and ultrasonography or here when it came up is also, these are 3 things that are increasing significantly in the literature, because you really have zero need for any invasive parameter. Swan and Gans, their first catheter was like a place where you just inflate the balloon through, and this is the catheter where they get the blood pressure in. This is their first patient recorded, and this is the tracing that they got. And it was simply, they were 2 cardiologists, I believe, they were, again, were interested in cardiology. It gives you a lot of information, gives you a determination of the intracardiac pressures. Through thermal dilution, you'll be able to obtain cardiac output. You can get blood samples to figure out different saturations, and you'll be able to determine, have some idea about some volume status, although it's not as accurate, and you can definitely calculate hemodynamic densities. Optimal use needs optimal application of it. This is just for you who are going to place few of them, and Nick, you're not going to place many, but you're going to see a lot of patients with pulmonary hypertension who will have it placed on the cath lab. And when you are under a patient with pulmonary hypertension, advanced pulmonary disease, you'll be able to at least go watch them. We do few. So what happens is this is what goes into the patient. These will go attached to a transducer, which is an electrical device, and from there it goes to a little amplifier, gets magnified, and goes to a recorder and gives you a digital image. This is the old transducer where you have kind of as water comes on it, it changes the resistor here. As the resistor changes, a certain current gets created, and this certain current is what you are recording and as a waveform. Remember that every time you're dealing with a hemodynamic monitoring system, you're dealing with a certain frequency response that has a natural frequency, and you will end up with dampening if it was not accurate. And because it's sitting in a mechanical thing, you may have exaggerated parameters by that. This is just a reminder of what dampening is. This is the concept that you have on your car brakes. When you push on your brake, there's a continuous fluid that gets from your little foot to the big wheels. So the pressure that you get multiplied by the little area is equal to the pressure multiplied by that gets there multiplied by the area of the wheel, and you end up with stopping the car. Same thing here. This is a patient. I have a continuous column of blood and saline to the transducer. Whatever the pressure changes here, it changes the same way here. If there's an air bubble, it would get dampened. So in reality, just when you push air or you push liquid through, you will have this is the adequate dampening, and you have a kind of half the way, and then it goes a quarter, and then it becomes normal again. Forget that. When you have this is appropriate. When you have, I don't know why this is this way, but this is overdamped. This is overdamped. So as it's coming this way. And when it's underdamped, it gives you several of them. Here you have to put the dampening device. Here you have to look for your blood clot or air bubble and then clean it up. Key for these numbers to make any sense is to have a reference to zero. And you have to reference it based on the phycostatic axis. And this is where our biggest problem comes, because they do it one time and later on in the day it changes, and so you get bizarre numbers all over the place. So you have to be very careful when you do it. It's like you have them later on. In reality, when you put a Swan-Ganz catheter, when the balloon is up, you're creating a continuous column of blood that's peaking at the left atrium, which when the mitral valve is open, there's absolutely no disease in the pulmonary veins, this pressure is equal to this pressure, and that's what you determine left ventricular and diastolic pressure, which is a correlate to left ventricular and diastolic volume. When you're inserting it, you have to get CVP, RV, a step up in diastolic pressure to see systolic, diastolic notch, diastole. And then once you wedge it, you would have a waveform that's a venous waveform. To know that you are in the correct place, this waveform has to be lower than the diastolic pressure of the pulmonary artery. This is just for a reminder of what these are. You have them with you on your slides. This is when you have wedge. You have to have a certain respiratory variation with it. If you don't, then you have to worry that you're not in the right lung zone, as I will tell you earlier. These are the assumptions that you have to make. To say what my preload is, you have to have all of these equal. There is nothing wrong at any level. Remember the west zones of the lung. West zone 3 is where your arterial pressure is greater than alveolar pressure that is less than the pulmonary venous pressure. In zone 1, the arterial pressure is much less, and then actually what you're recording is the alveolar pressure. And in zone 2, it's somewhere in between. To tell that you are wedging in the right zone, there are several techniques that you will see, like there are tests basically. And this is, when you put the balloon up and you collect blood, it comes back at you. And when you send it for analysis, it's arterial blood, because you're getting it actually from the left atrium. Left atrium, or just before it, like the pulmonary veins. And then when you are not really sure, you play a little bit with PEEP, and if you change the PEEP and the change in the pulmonary artery pressure is greater than half the PEEP that you apply, you know that you are not in the right place. When you give a fluid challenge, usually the wedge pressure increases and there's no change in underwork. And lastly is your chest X-ray, you are above the atrium. If you are not in zone 3. In zone 3, you have to be below the atrium at all times, radiographically that is. This is the effect of PEEP on the wedge pressure, and it helps you when it is low. If it is not low, if it's high, when you have somebody with left ventricular disease, you don't know if they are fluid responsive or not. You have to try it. So when it's very low, it's helpful, but when it's high, it's not. Also remember that whenever you have a PEEP applied in somebody with an injured lung, your pulmonary capillary wedge pressure is what oozes blood out is not equal to the wedge pressure. It's a bit higher than that. And it's about 0.4 multiplied by your PEEP, pulmonary artery pressure minus your wedge pressure. You can also determine the cardiac output by injecting cold saline or just through air saline, and you have because at the tip of the swan, you have a little bit of a thermometer, and that thermometer, because as you put the cold saline in, it's going to warm up, and you pick it up there. There's a Decatur curve of the temperature, and you can determine the cardiac output by this, where K1 and K2 are a function of the swan gas catheter. That you're going to see a lot with pulmonary hypertension, and I urge you to learn about it, and because your opportunity to learn from swans is decreasing over time. This is just as a kind of reminder that this exists, carbon dioxide they're breathing. We used to have it, and this is how it calculates it, and the importance of calculating this is to remind you how to calculate cardiac output by a Fick equation. But the trend is going towards the arterial pulse contour analysis, which is pretty accurate. But in addition to getting stroke volume and cardiac output parameters, you can get how much of water there's in the lung, what's happening at the global and diastolic volume and thoracic blood volume. And this has been used a lot still in research in ARDS to determine how much extravascular lung water that exists. And in reality, when this is from PICO, this is how it determines the cardiac output. This is the formula by which it uses it. The advantages, everything has advantages and disadvantages. It's relatively minimally invasive. Because you only need an arterial line and a central line, which is very commonly used in patients with sepsis. And it will give you a beat-to-beat information. For your interpretation of it, because you are looking at pulse pressure variation and stroke volume variation, you need somebody in sinus level, which is not always the case, and you need somebody on mechanical ventilation with high tidal volumes. The two leading companies that does pulse contour analysis with calibration is the Litco, which uses lithium to calibrate the machine, and you have to do it once a day, and the PICO, which uses like saline to calibrate once a day. And then there's the flow track, which is by Edwards, that really uses all data, like accumulated data over years, and they use the artificial intelligence of the machine to determine what the compliance of the vessels are. And because they determine the compliance of the vessels, they can determine what the stroke volume is based on if they have a pulse pressure variation. This is the difference between transpulmonary versus pulmonary artery thermal dilution. Here you inject through the central line, but your temperature is at the arterial line, so it's actually a transpulmonary cardiac output, where the other one is you're giving it from the outside through the vein into the pulmonary artery. The difference in calculations is a little bit different with those. Let's come now to the aortic pressure velocity. This is like when you have a Doppler, like an esophageal probe with a Doppler attached to it, and you put it at the level of the aortic root. You'll be able to determine the velocity of the blood passing through the aorta, and similar determination can determine the variability in velocity. And this variability correlates with the stroke volume. And here it's like at least the first people who did it, they determined the discrimination between responsiveness and non-responsiveness to be equal to 12%. Problem always, if you have somebody with right-sided heart disease, lung disease, and ARDS. Um, it's the same. It's like, so if you're sitting there and you're trying to calculate the stroke volume or the transthoracic echo, you can do it the same way. It just takes a little bit of a longer time. Currently, our machine, you have to do it manually in the ICU. If I'm lucky, you'll get a newer one that will just identify it for you and will calculate it automatically. Using this for when your legs are up is very possible, but before you do it, you have to have very good 5-chamber view when you're doing the echo. And once you get it, you determine your baseline, and you do the straight leg raising with your probe on, count up to a minute, and then redo it again. And that would be the way to do it. This is how you see. This is the transsesophageal one. You have to put it where the aortic root, where the descending aorta starts actually. This is the concept behind how this correlates with the stroke volume. How this correlates with stroke volume. So this is it's the cross-sectional area from of the aorta multiplied by the distance, which is believed to be this velocity relay. Okay, all right. IVC, we're relying a lot on it, although it has several pitfalls with it. The Society of Echocardiography has put guidelines to determine what parameters to say that they are collapsible or not collapsible or distendable actually. You want to have this image before you make your calculation. You want to be about 2.5 centimeters away from the hepatic vein. And this would be where you want to put your Doppler at. Not Doppler, the Hemodynamic. And if you have a good respiratory variation between inspiration and expiration, this is somebody on a ventilator, so on the ventilator with positive pressure ventilation, the RBC would expand actually during inspiration. This is the calculation part. You can sit and calculate it by yourself. Pitfalls. Remember, when people are breathing, there's always motion artifact. So you have to be careful where you put your probe and you're getting the same image during inspiration and expiration. Don't confuse the aorta. The aorta doesn't move much. Always try your best before you determine your calculations that you are you know where the aorta is, and you know where the IVC is, and you know that you are at the IVC when you see it and you see the common vein leading into it. That's like very, very crucial. If you don't see that, problem. If you see the IVC crossing the diaphragm, then that's also a good hint. If you're seeing it entering the RA, that's a great hint. So if you have these 3 parameters, are 100% certain that you are looking at the aorta, at the IVC. These are the how you determine the distensibility and collapsibility in these people. The one thing that is actually we have, so the echo we have, so we can use that. The new tool that we got into the MICU is the Hejal non-invasive cardiac monitoring device that uses the bioimpedance or bioreactance, I should say, technology, which means that you have 4 sensors that you apply on the chest. There are actually 8 of them. The outer sensors send an electric current, and the inner sensors collect the electric current and displays it on a monitor. When they do that, the difference between so if nothing moves, I put an electric current, I should get it back. But when what happens in the chest is there's a heart by heart beat, right? So because there's motion and because something is exiting the heart, there's going to be a delay of the waveform coming back to you. And this delay is what you rely on to determine the stroke volume. So this phase shift that you will see, this part of the graph correlates with your stroke volume. So the machine itself looks at this and kind of develops its own waveform because it changes over time. And this part correlates with the stroke volume. And so there's a calculation that you have for it. And this is what you get. And the machine itself will display to you what the stroke volume is. And if somebody's on the ventilator, it will actually give you what the variability is. But this one, just ignore it. Just go by this one, lift, predetermined, and calculate the difference. That is 10% or above, then you know that this is the case. Now the lifting part is also guided by the machine. There is a little gadget that is 45-degree angle that the nurses will put underneath. And 1 minute, you tell it to push the button that I'm starting the test, you put it, it will start recording for you, and it will give you the outcome of it just immediately afterwards. There is the arterial plethysmography that people have used, where you put a kind of literally a blood pressure cuff on either one of the index fingers, and you will end up with a waveform, an arterial waveform from the capillaries. And the same concept. This area under the curve correlates with the stroke volume, and you can determine the pulse pressure variability. The problem is, a lot of people are on pressors and they have that, the blood pressure becomes very dampened and you cannot see it. So the volume clamp technology has failed us. All of these exist, we're not gonna buy them all. I'm just arguing for getting one contour, pulse contour analysis, so we have at least 2 modalities to work with. Summary table. This is referred to as impedance cardiography. So there are a couple of machines that does it so that it's not really outcome. And then from this, knowing what we just know, we have to create a certain algorithm by which we do things. This is what was recommended by, by one company. I forgot which one it is. What I don't like about it is it puts us in stroke volume variability rather than a change in stroke volume. Stroke volume variability means these people are on a ventilator. And so I have it here just in case one wants to use it. This one helps a little bit to determine if somebody is spontaneous breathing or not spontaneous breathing, so it takes you one way or the other. Regardless, it looks like passive leg raising is on both sides of the corner. And this is what we're going to try with the help of Kaylee and Martin modify so that we can use as a standard of care for our septic individuals. Remember, numbers mean something, but they have to mean something. So don't get trapped with numbers, just get trapped with a little bit of concepts. I'll stop here and if there are any questions.
I'm trying to, so this is all very cool, the stroke log variations and all the different ways we can measure. I'm guessing that the idea is this will better guide therapy for someone in shock. You have the clinical question, my patient's in shock, will they get better with volume expansion or not? And then maybe you can get an answer from using these techniques. But at the same time, I'm just wondering, what is the ultimate goal of answering, because the patient wasn't responsive or not? Is the idea to use less fluids? Is it
No, the idea is to use more fluid when need be, varying pressures when fluid responsiveness doesn't exist.
Okay.
So all these tools, remember, are physiologic at this point in time. None of them has been proven to optimize patient care or decrease mortality in anybody.
Right.
Some of this one gets that. It depends on how you use the numbers. And it depends on what you're trying to do. This is why, for us, it's going to be optimizing sepsis care.
Mm-hmm.
Sepsis care, and hopefully at some point in time we'll talk about, I'm sure we have some sepsis talk on board. To optimize sepsis, remember the first 3 hours of care you have to guarantee according to whatever body you need, a certain amount of volume. At this point, they claim that 30 cc's per kilogram is the optimal volume.
Right.
What we claim is based on this data and a lot of studies that 30 cc's per kilo is not a uniform that will fit everybody.
Mhm.
So we have to tailor it. To tailor it, you have to tailor it towards some idea of how much to give.
Mhm.
So you don't have to use any of these tools. You don't have to use anything except for perhaps your clinical judgment. And try to imagine what your stroke volume is.
Yeah.
So if you were to sit there and say, I'm just gonna lift somebody's leg, so I'm gonna give 500 cc's of the bolus, and look at what happened to my systolic blood pressure, and keep on doing it until I don't have any further change, check, that's important, that's good. You don't have to use anything else.
Yeah.
So it depends on how you want to get it. If you're somebody who's interested in actual cardiac output optimization and you want an actual number that is consistent every single time that you're doing it, then you have to use some tool that is consistent.
Sure.
So that's your question is extremely important, and the answer to it, none of these have become standard of care.
Right.
And there's nothing, actually there are several studies that compare this to that, they're all the same.
Right.
It depends on how you use it in your algorithm.
Yeah. I guess that's what I'm trying to just, are any of these superior to a empiric, fluid bolus and clinical reassessment?
Never done.
Oh.
Never done. Actually, the people who did it is a group of people in Thailand who didn't use anything. They just used quarts of fluid, but then stopped and started early pressures, and those people survived better than the ones that you blindly give 30 cc per kilogram without any intervention. But the only advantage of knowing this is you need to understand the language when you're reading something about it, and if you have the capacity to monitor over time, look at what you're monitoring and the faults of each one. Whether we like it or not, clinical judgment is not always a valid tool, because our patients are not necessarily very operative.
Right.
But anyway, that's good. Good?
Yes.
Thank you.
Hey, you guys outside, do you need anything?